Being a part of the American healthcare system as a nurse can be incredible, and it can also be infuriating. Today, we're going to talk about the American healthcare system and what we need to know about it as nurses. This video is about the American healthcare system, and it's part of the community and public health nursing course. And this is really what we need to know as pre-licensure generalized nurses about the American healthcare system. Let's get into it. So we've got 1, 2, 3, 4, 5 learning goals for today's lecture. We're going to describe the structure of the American healthcare system. We're going to describe how healthcare is funded in the US. Money makes the world go round, right? We're going to explain the difference between public and private healthcare organizations. We're going to discuss laws and policies which impact the US healthcare system. And finally, describe the connection between healthcare quality and cost. Let's get into it. The American healthcare system, you can think about being divided into 4 quadrants of care. You have your community health, which is things like preventative care, health screenings, chronic care management to prevent them from getting worse, and general population health. And then you have your ambulatory care. And I like to think about ambulatory care like you walk in, you ambulate, and you walk out. So things that are same day kind of treatments, primary care, same day surgery, diagnostics and testing, and medical specialists. Long-term care is for patients who have long-term chronic needs, things like home health nursing, hospice, skilled nursing, also known as nursing homes, and acute rehab facilities. And then finally, acute care. This is your emergency services, your medical and surgical care, as well as discharge planning from the hospital. Now, you can imagine that acute care is probably the most expensive resource of our American healthcare system. And we're really trying to move towards more community health, more ambulatory care, as they are much more cost-effective ways to care for people. Not to mention we keep people healthier that way. Now, healthcare organizations in America can be divided into private or public. When you think public, think government. When you think private, think non-government. So private healthcare organizations are for-profit or not-for-profit hospitals or clinics, insurance companies, pharmaceutical companies, medical supply companies, and so on. And the public healthcare organizations are all under the umbrella of our government. Specifically, on the federal level, they're under the Department of Health and Human Services. In fact, the Department of Health and Human Services has 12 different divisions, and I haven't even listed them all here. But here's a sampling of those. Administration for Children and Families, Administration for Community Living, Healthcare Research and Quality, CDC, Center for Medicare and Medicaid, Food and Drug Administration, HRSA, Indian Health Services, National Institute of Health, and Substance Abuse and Mental Health Services Administration. So this is just a few of the many things that are covered by the Department of Health and Human Services. Let's talk about a few of these a little bit more. Healthcare Research and Quality is a research branch of the government. The CDC is in charge of preventing any infectious diseases and protecting our community from illness. Center for Medicare and Medicaid Services is in charge of Medicare and Medicaid. The Food and Drug Administration is the one that regulates our medications. The National Institutes of Health is another research branch offering clinical practice guidelines for providers. And I think that's enough for now. Healthcare funding comes from both private and public insurance. Private insurance is employer-provided insurance. It's tied to someone's job. And examples of this would be Aetna, Blue Cross Blue Shield, Humana, Cigna. And these can be either HMOs or PPOs. HMOs require that a patient go to their primary care doctor for all needs and then get referrals to specialists as needed. A PPO gives patients more autonomy and they can go directly to whatever service they choose that they need. For example, if I was having a back pain and I wanted to go see a chiropractor, if I had an HMO, I'd have to go to my primary care doctor and get a referral for the chiropractor. But if I had a PPO, I could just book an appointment with the chiropractor. Now, public insurance is government, taxpayer funded, and sometimes requires payment by the individual to be a part of it, like Medicare. And there are requirements to qualify for the various public insurance options. So let's talk about those. Some of the public insurance options offered by the government are Medicare, Medicaid, CHIP, TRICARE, the Federal Employee Health Benefits, and the Refugee Health Promotion Program. Medicare is for patients 65 and older, patients with end-stage renal disease, or those who are disabled. Medicaid has funding from both the federal and state, but is administered by the state. So depending on what state you live in, you would get Medicaid from that state. And eligibility is based on the state threshold of what they set as the poverty level. So Medicaid is for people who are in poverty. Now, CHIP is funding by the federal and state government. It's administered by the state, like Medicaid, and it's for children up to age 19 years old, just children up to 19 years old. And it's for children of parents who can't afford private insurance, but make too much money to qualify for Medicaid, that kind of funny middle. And so it makes sure that children in this age group are covered. TRICARE is for active military and their family, also military survivors and Medal of Honor recipients. The Federal Employee Health Benefits is for federal employees and families. And since there are so many federal employees, it is the largest employer-sponsored healthcare program with 8 million people enrolled. And finally, the Refugee Health Promotion Program offers medical and dental care for people who are in the United States seeking asylum. It's offered by the Office of Administration for Children and Families, and just like Medicaid and CHIP, it is administered by the state. Now let's get into laws and policies. The first couple laws are in response to some things that were going on in the 80s in the country. And the government stepped in and said, okay, hospitals, you actually have to take care of patients better than you're doing. So what was happening with COBRA specifically, this Consolidated Omnibus Reconciliation Act of 1985, there would be a patient that come into the hospital and they're really, really sick, let's say sepsis. And they would pull up the patient's insurance and be like, oh, this patient does not have insurance. We don't want to have to foot the bill for this patient. You know what? Let's just call an ambulance and we'll just send them over to the hospital on the other side of town. So they would call an ambulance. They wouldn't call the other hospital or let them know or get permission. They just call and send them away to the other hospital. So then the ambulance would show up to the other hospital and the hospital would say, oh, this patient does not have insurance. We don't want to foot the bill for this. We're not going to take this patient, and so on and so forth. And it was called patient dumping. And hospitals were getting really sneaky about this. And so the government intervened and said, listen, hospitals, you actually can't dump a patient just because you want to. And so you have to, if you want to transfer a patient, you have to fill out a whole form. You have to have permission from a nurse at that hospital, a doctor at that hospital. You have to get consent and so on. So it protects patients from just being dumped by a hospital. And then the other thing COBRA did was provide an option for temporary insurance after the loss of benefits. So if you ever had a job with benefits and you leave that job, you have the option to pay out of pocket for COBRA benefits to cover you for a few months. The other thing that the government did in the mid-80s was EMTALA, the Emergency Medical Treatment and Active Labor Act. So this was another thing that hospitals were starting to get sneaky about, is patients would come in with severe illness, or maybe they were in active labor, and the hospital would look at them and say, well, do you have insurance? And they'd say, no, I don't, but I really need help. And the hospital would say, too bad, so sad, goodbye, and not help these patients. And so the government got involved and said, listen, hospitals, you cannot turn away a woman who is in active labor, and you can't turn away someone who has a medical emergency, a true emergency, not a little sprained ankle, not a little, ear infection, but a true emergency. And so patients are covered by this. Now, EMTALA only applies to hospitals with an emergency department. It doesn't apply to a specialty doctor or some kind of clinic. It really is people who are seeking emergency care. Finally, the Affordable Care Act, which was enacted by President Obama, requires coverage of dependents up to 26. It used to be, I think it was 18 or 21, it was much lower, requires some coverage for pre-existing conditions and requires coverage now for preventative services. So it expanded coverage for millions of Americans. The next thing I want to talk about is quality and cost. Healthcare is an extremely costly component of the budget in the United States. And Medicare got smart and said, we want to make sure that we're paying for things we're getting our money's worth for. So in 2013, Medicare started value-based purchasing. And what value-based purchasing does is it withholds 2% of Medicare payments from all hospitals. It just says, we're going to hang on to this last 2%. We're not going to give it out yet. And then it takes that 2% of what they owe all the hospitals and redistributes it to the hospitals with the best scores. Hospital best scores looks at things like mortality rates, healthcare acquired infections, getting pressure ulcers or catheter infections in the hospital, patient falls, patient experience, how happy are your patients, and efficiency and cost reduction, specifically length of stay. Are patients staying in the hospital the amount of time we think they should based on what their diagnosis is? And so when hospitals perform well in these areas, they get a distribution of that extra 2%. And this can add up to hundreds of thousands, if not millions of dollars for a hospital. So hospitals are really motivated to have good quality outcomes in these areas that really matter to patients. And by doing so, it also keeps costs down. Another thing that keeps costs down is a focus on prevention. It is way cheaper to prevent an illness than it is to treat something. So primary, secondary, and tertiary prevention is all focused on preventing illness from happening, screening and catching it early, and managing complications for people who already have chronic disease. And finally, there is a shift to focusing more on home health over hospitalization because it is much more cost-effective to do so. There are a lot of benefits to working in the American healthcare system. There's also some things that really make it infuriating, especially as we're advocating for our patients to get the care that they deserve. But knowing about the system really helps you be an advocate and helps our patients navigate the system better. Thanks for listening. Remember, as always, you are smart, you are capable. You are loved, and you got this. I'll see you next time.